Dr. Jose Burgos, thank you so much for your time today.
Thank you.
I'm honored and excited and very thrilled to introduce you to, my viewers and anyone that really cares about doing a good job with taking care of their health and doesn't know where to start, number one. And number two, when they or their loved one is facing something very, more intense, chronic, or, potentially terminal illness, to have somebody that can really help them through that. I think that that's very important. And a lot of people, when they come across a health situation, they don't know where to start. They don't know what to do. So I truly appreciate you taking the time to explain to us a little bit more about palliative care, why it matters to you, and how you choose to help people. So my first question for you is, what do you want the community to know about you right off the bat?
Oh, well, that's a good question. Well, first and foremost, I'm glad to be part of the digital community. I'm not as involved as I would like to be, because I'm in the forefront of healthcare by being in the hospital, by assisting in post-acute care settings, which is rehab facilities, nursing homes, urgent care. And I like to assist and provide resources to the community so they can have access to care. So if there is something that I want people to know, is that physicians are very much underrepresented on social media.
I agree.
We have a lot of pseudo experts.
That's the problem.
with a very loud voice and a premier presence in social media, and it seems at times that presence overpowers knowledge, experience, and most importantly, liability.
Oof.
Whenever I say something, even through this channel, what my words portray is several years of not only training, but experience. I have 20 years of experience being a physician, but at the same time, research.
Mm-hmm.
Most importantly, whatever I say carries liability, because if I give you right now a bad advice, this is recorded.
Mm-hmm.
Even though it's not a medical consult, somebody can listen to me and do something based on my words.
Mm-hmm.
If that has a negative impact on their health, I can be liable for that. I want to ask how many people who are giving advices in social media can do the same. So it's very easy to speak your mind without any fear of causing harm when you don't have skin in the game.
Yes.
And physicians, practitioners, we all have skin in the game. We can lose our license if we're not portraying real medical information. We can be subject to lawsuits. A bad lawsuit can end our career. I mean, just remember something. Nobody's practicing medicine to cause harm.
Yeah.
We don't spend 10, 15 years of our life to obtain a license just to throw those 15 years knowledge, experience, expertise, and a way to provide to our family members by just doing harm purposely.
Right.
So just remember, check the sources of the information when you are trying to obtain healthcare information.
I think that is so important. And there's been a big scandal on social media too about a therapist that was saying that she was calling herself a therapist, calling her name doctor. She was saying doctor in her name, but everyone said, well, where's your degree? And she never has produced the degree.
It happens frequently. And one thing that I would like people to know about me, you might see me on TV at times, you will see me when you're really, really sick. But one thing that I'm always doing is I'm always trying to understanding the needs in the community. I'm always trying to facilitate access to healthcare. Mm-hmm. And I do that 24/7, 365. That's a little piece of information that a lot of people don't know.
Okay.
That's why I am involved in so many medical ventures.
Okay.
Because they make sense with one another.
Just a supportive
in order
ecosystem, right?
Yes, exactly. To create a good, complete healthcare ecosystem. where people can have just more access, more options throughout the community. And that's my goal all the time.
That's wonderful, because here at My Health Primary Care Clinic, this is my first time here. It's a lovely, very warm space. And I did notice that you have several different providers here.
Right. I do not, practice primary care medicine.
Okay.
I'm an internist. Even though I'm trained for it, I focus mainly on hospital medicine and post-acute care medicine, which is care for hospitalized patients in rehab facilities, nursing homes, hospitals, definitely. That is my main focus, and obviously palliative care, which is something that I've been doing over the past few years.
Okay, fantastic. So when you say that you support people to have access to healthcare, what exactly do you mean by that? And the different kinds of healthcare? Do you mean that because you say you work as an internist?
As an internist, a hospitalist based at the University Medical Center of El Paso. So for the last few years, my goal at the hospital has been to improve the inpatient care, to reduce the hospital stay so we can become more efficient, and obviously make sure that the patient gets better rapidly and goes back to their normal life as soon as possible, be productive, be happy, and fulfill, their life goals again.
Yes.
Being in that particular setting, then I learned a lot of deficits we have in the community and in the healthcare system overall.
Okay.
People always count with their primary care physician, but in El Paso, we are an underserved community for primary care doctors. So there's definitely a need in there.
Okay.
Urgent care clinic. That's why, I'm part of UCare clinics in El Paso.
Okay.
We do not have a lot of private owned research facilities. That's why over the past 15 years, I have opened 2 of them. One that focuses on therapeutics for rare conditions, one that focuses more on diagnostic conditions.
Oh, wow.
So we can bring clinical trials to El Paso. Actually, the first COVID vaccine that we had in the area was brought by El Paso Medical Research Institute, which I own. And
is that right? Oh, wow, that's amazing.
We were moving, everything in our power to provide access to that,
especially quickly, because here in El Paso, we were the epicenter of COVID for a minute, right? That was horrible.
At the forefront, seeing people, getting sick and unfortunately passing by the day. When our patients leave the hospital, they, in order to get them completely recover so they can go back to their normal life, sometimes they need a little push. That push can be a little rehabilitation, which can be in an inpatient rehabilitation, can be in a subacute rehab center, which is skilled nursing facility.
Okay.
They might need long-term care. They might not be safe to return to home. They need to go maybe to a nursing home, to a foster home. Okay. Some patients actually cannot even move out of their houses because of their condition. So my company also can provide care at home. So I have surrounded myself with an incredible team of people to provide care at different ends in the healthcare system. And, it's not over. We're still looking into what other needs are in the community so we can bring them and fulfill those needs.
That's fantastic. Especially, you being a hospitalist. So are you part of the discharge process as a hospitalist, right?
You're helping the admission to the discharge process.
Oh, okay.
Everything.
Okay, because I used to, I was a community liaison with the home health care agency, and I did that for about a year last year, and I saw a lot of challenges there too, like just with the communications and how can the at-home specialists and the skilled nurses, how can they communicate better with the primary care physicians and the hospitalists once people leave? I think I'd love to know this. Once people do leave the hospital environment, is there a reason that we would need to still keep in contact with you? Is there anything that you as a hospitalist would like to know once that, from a home health care agency or from their primary care physician that would be helpful for you?
Well, sometimes, our goal in any healthcare facility is to make sure that whenever a patient is discharged, they actually remain doing well and recovering and productive at home. Okay. We do not want to see the patients coming back again because it means that either we fail at some part of the process or the patient didn't have enough support and then they fail because of that. So obviously we want to make sure that patients have everything they need as far as medications, follow-ups, timely follow-ups with their primary care physician, and their rehabilitation needs are met. So that way they can really thrive and, improve.
Yes. Do you get a report back from every person that you release, or
only if needed?
So that's more for that ecosystem picks up at the primary care level.
Ideally, that is ideally what should happen. The primary care physician typically takes over after the patient leaves the hospital.
Okay, which I think is a great segue into palliative care, because that's kind of the gap, right? In
Definitely.
some certain situations.
The problem with palliative care in the community is that a lot of the physician and providers are not completely familiarized with the concept and the utility of it.
Yeah.
So my goal initially as a hospitalist and then as a palliative care specialist is to educate not only the community, because they are the ones who will receive services, but to educate physicians and providers so they understand really what palliative care is about, so they can offer this service to their patients at the right time. And this is a reality also for the hospital. Engaging the palliative care specialist in the hospital, the earliest, typically that's when we have better outcomes for patients and for hospitals.
That makes most sense, because that means that there is a medical doctor who is overseeing the situation. They're communicating with the patient's team within the hospital. But then what I'm understanding from what we briefly discussed about palliative care is that this palliative care doctor would be able to they would kind of be the bridge between the hospital stay and the primary care physician and the aftercare. Is that correct?
Yes. The issue is that anybody who has a chronic condition that has no further alternative to be cured, that are advancing rapidly, that is causing the patient to deteriorate, that is actually jeopardizing the life of the patient. We all know we will die one day.
Yes.
The question we have to ask ourselves is, do we have a condition that ultimately, once it becomes complicated enough, is going to be the cause of our death? If the answer is yes, then palliative care most likely is better earlier than later. And palliative care is just more than hospice. It's actually much different from hospice care. A lot of people tend to intertwine both concepts.
Yes.
Hospice care is the care that somebody receives when their life expectancy is 6 months or less.
So that's very defined. It's very strict definition.
Very strict, because it is insurance driven. You have to qualify under certain diagnosis and certain prognosis to receive hospice care. But again, we're talking 6 months. Obviously, based on per calculation, some people will last way longer. Actually, I've seen patients who start the process of hospice. They receive such good care that their life expectancy actually goes beyond a year, because they are receiving continuous care at home, much better than the care they were receiving by their family members and maybe just plainly a home health agency.
Yes.
People who are not even able to get up and go to see their primary care physicians, and they are not receiving real-time medical care. So I've seen that as well. But the definition is somebody who has a condition that is progressive and has a life expectancy of 6 months or less if the condition continues to maintain its course. Now, palliative care is much broader. Palliative care has a much more complex concept. So you do not have to be terminal to receive palliative care. All right? If you have symptoms that are difficult to manage and you have a condition that doesn't have a treatment that can be cured, then you might need palliative care, because palliative care specialists can treat pain very aggressively, can treat a lot of symptoms very aggressively in order to improve the patient's quality of life. Now, a palliative care specialist is part of the healthcare environment. You will keep your primary care physician. If you have an oncologist, you will keep your oncologist. If you have a cardiologist, a pulmonologist, a rheumatologist, any other specialist.
Okay.
You will keep them, and then the palliative care physician will be part of the team. Now, the advantage is that the palliative care physician will connect the primary care doctor with the other specialist, and will most likely take over of managing the worst part of the condition, so they can be on top of it. For example, if we do pain management, we know that a lot of pain medications available in the U.S. they are controlled substances.
Mm-hmm.
They require very strict monitoring. They require very particular, specific type of prescription pads or permits from the physician. And a lot of doctors, they shy away from doing this because of the legal implications that they have. Now, a palliative care specialist will take over no matter what, own the situation, and help the patient as much as they need in order to make sure that all symptoms that are affecting their life are controlled.
Oh, wow, that's fantastic. So because the palliative care physician is well versed and it's their job to manage that part of their life, then that's what they're going to do. They're going to be able to focus on that, to whereas the primary care physician they just don't have the time. Like you said, we're underserved community, right?
Or even the training. I mean, pain management requires training.
Oh,
right. You can
okay.
see a pain specialist, but pain specialists, even though they can definitely manage the pain medically, for the most part, their focus is to manage the pain interventionally. Like, for example, you have a nerve type of pain that requires an intervention. That's their main focus. Obviously, they can do pain management medically as well, but they will focus more on the procedural side.
Oh,
Your primary care physician might not feel comfortable adjusting high doses of opiates.
Yeah.
Managing some of the complications from the opiates. That's when your palliative care physician comes into place. And it will start taking over a lot of other things.
Mm-hmm.
Let's put another scenario. You have an advanced cancer.
Okay.
Your oncologist theoretically could manage your pain. Now, the oncologist does not have the entire training to start like shifting medication, adjusting, doing all these things. That's when your palliative care teams up with your oncologist, so they can be on top of it. Plus, you will probably be able to see the palliative specialist much sooner than any other doctor because they know that active symptom management is key.
Wow.
Or you might need to see your oncologist in this week, but they don't have an appointment for you until next month. And then you will run out of medication, might go into withdrawal, go to the emergency room. I mean, have complications because of that. So the palliative care specialist is the one that should connect you with every other specialist, understand your condition. Sometimes we actually tend to put together the plan in a much more concise way that is easier for the patient to understand.
Okay, yeah. And you can take the time to explain probably how all the parts are working together. Is that something you can help the patient understand? Because I would imagine that if you have an oncologist, you have a primary care, I know people that, they have a kidney specialist because they, dealing with diabetes. They, have an eye doctor. They've got all these things. And maybe with the palliative care, you might be able to see things that other doctors can't see because they just don't have the bandwidth to go that deep on every patient.
They are seeing their organ and only their organ.
That's right.
And that's why we are a healthcare team. We work together. That's why everybody has a different specialty. Mm-hmm. Because I cannot handle everything on my own.
That's right.
So I have to obviously put my expertise to work. A neurosurgeon, you say, a neurosurgeon is an expert on their field, right? I cannot operate on a brain. Yeah. I cannot remove a tumor from somebody's head. I will need a neurosurgeon for that. But then sometimes the neurosurgeon might look at the images and say, yeah, I can remove that tumor. But then when we come, we say, just hold on a second. Let's analyze this patient a little bit more. People get offered palliative care, and then they say, well, does it mean that there's nothing else to do?
Oh.
And that's far from what it is. There might not be a therapy or a treatment that will reverse the condition. But now we have to enter the the reality where we have to focus on treating the symptoms aggressively and make sure the patient is comfortable, make sure that the quality of life is maintained if there is some quality of life, or that it improves. And maybe we did reach the end of the road, and now we have to focus on making sure that the patient passes with dignity, with no pain, in the best possible scenario, without any unnecessary suffering, which is something that a lot of people fail to see. And we need to realize this early enough so we can prevent having an ugly death.
An ugly, ooh. That, wow, I don't mean to laugh. It's just,
It's shocking.
It was shocking, but I think it's so true. I mean, I know it's true, and I feel like our society, and that's part of why I wanted to have this podcast and to highlight experts like you and bring these conversations forward. Because, like you said, medical professionals are very underrepresented on social media, actual ones, and especially local ones. And let's face it, every single person in the borderland is going to either need care. Eventually is going to either need long-term care, or they're going to be caring for somebody that needs long-term care. I mean, that's the reality of life, so this is a conversation that's never going to go away, I guess, unless that Brian Johnson, have you heard of that Brian Johnson, the longevity guy?
Right. I mean,
unless that happens, but I'm willing to bet it would be a long time before the average Joe would be able to take advantage of those benefits.
It's very expensive too. And a lot of those things are experimental, so you just have to take the risk.
Yeah.
When we studied palliative care, there were two concepts that actually were a little bit shocking, or even awakening for me. The first one is a concept called total pain. Oh. And then another concept is the beautiful death. So when we talk about total pain, it's not only that physical pain, it's the physical pain, it's the emotional pain that the condition brings. It's a psychological pain that the condition brings as well. And it's a pain that is inflicted on your family as well. That is total pain. That's
total pain. And then the pain you feel from inflicting the pain, from the pain inflicted on your family. I mean,
so when we do palliative care, we practice palliative care, we do not focus on the physical pain only. We focus on the total pain.
Oh, that's beautiful. And that's important.
Otherwise, you're not doing the job completely.
Because when people, and I also believe that too, and I'm sure, I'd love to hear your experience with this. When you do have that total plan, and you said how was it? What was the other part?
The beautiful death.
The beautiful death, and I'm going to take a shot at what that means. But I'm thinking that this is when it's not it's one of those situations where you know that you've reached the end of the road of a certain condition, and that it's the management side and it's the reality side, and you have someone like you, Dr. Burgos, who is a palliative care specialist, and you're going to be able to say, okay, have that real conversation with people, which, like you said, I'm sure is hard, but it's so necessary. You're giving people that opportunity to get real, for lack of a better term.
Without any unnecessary excuses, because time is of the essence. If you don't have a lot to live, I do not want you to be blindsided by your own condition just because someone doesn't want to tell you things as they are. So, for example, when on the total pain subject, I tell patients and I tell family members and anybody who is involved in the care of that particular person. Of course, I mean, the patient is the patient, but then everybody in the close circle, they become the patients as well, which is something that in our day-to-day medical practice, we might not necessarily practice that way, but I think it's very important that in palliative care, we do that, because at some point then the patient is not going to be able to take their own medications. I need to involve them. I need to let them know what to expect from the physical component.
The side effects and such?
And actually the overall prognosis diagnosis.
Okay. Oh, okay.
Decisions, hard decisions that are going to be made. So we do need to focus on that a lot more.
I think so too, because I can think of personally, just in my life, and they both since passed away, my father and my grandmother, and they both just got the runaround. I think, like now in retrospect and hearing you talk about palliative care, and my dad was in so much pain. Now, as a patient, it's his right to share that with other people or not, and to include that. So I know that is a factor. And so, do I think that he would have told us that he was dying, even if he knew it? No, but I don't think that he had that idea that death was on his door. But in retrospect, as the living caregiver and family member, you're just like, they were clearly like failing. Things were failing and nobody was saying anything. Same with my grandmother. I was with her in the hospital room. She was supposed to be in the emergency room, but the emergency room was short staffed. So she was in like a regular room. The nurses were short staffed, and she had diabetes. But I didn't realize this whole thing. She was hungry, and I told the nurses that my grandma's hungry, and my other family members had told me not to get her fried chicken because she was so swollen that just from what was going on with her, she had just been moved out of one hospital to a skilled nursing kind of facility rehab, but then she came back because she was swelling.
Right.
So, and then when she was at the first hospital, she was bleeding out. It was dark, very dark, and it was just like and then just pee, but it was like pee, but it was all like blood. And they were telling me, like, it looks bad, the nurse was like, it's not as bad as it looks, but they were, and when you're young, and I'm talking about this because I see where you're saying, because when you're young and your family, the way that they do healthcare is going to the emergency room, which kind of happens, in certain families. And you're not a medical professional, you take your medical professional's words.
Yeah, when you use emergency room as your primary care physician, your care is fragmented and it's not going to work out. Emergency rooms are for actual emergencies only.
Yeah.
Primary care medicine is to maintain health and do preventative medicine. That's how we stay out of the hospital and out of the emergency room, by going to your primary doctor at least twice a year if you're healthy.
Yes. And so I'm just thinking, of my grandmother and my father. I'm thinking there was clearly something more chronic, going on with them. You know what I'm saying? And they would have had a palliative care medical professional doctor, then I just believe, just like you're saying, that their whole experience would have been so devastating. It would have went different because they were clearly dealing with health concerns. It wasn't like they were in perfect health and all of a sudden something happened. So and being able to have that conversation and that mindset of, we need, that this is really where they are. It's scary, but you'd rather have it than end up losing them in the emergency room like we did with both my father and my...
Yeah, there's no way. I mean, that's when the concept of beautiful death comes into place.
Yes.
So what is it? I mean, obviously, death is not, in our culture, at least in Western culture, death is never looked as something beautiful.
No, we act like it doesn't exist.
Yes,
you know what I mean?
You just hit it right on the head. We ignore death like it's something that will never happen. But obviously, you're born. After you're born, the only thing that is guaranteed is that we are going to die. And actually, a lot of people ask me, like, why do you practice palliative care? It's so sad. And I'm like, it is sad.
It is sad.
But at the same time, just look at it. When we have somebody who's pregnant, everybody's celebrating that life even before it comes, right?
Oh.
And we do baby showers, and we're there when the baby's born, and we're celebrating, the first few months, and we're on top of it. And whenever death comes, for some reason, for a lot of people, it seems to be a surprise and a shock. When actually, if you have a chronic condition, if you're after a certain age, I mean, you might anticipate that the risk is there, that death is coming. Yet we kind of like turn the blind eye towards that situation, and we are rarely there when our dear, or our family members are in the dying process. And my team from the inpatient hospice at Hospital of Casa, I always tell them, I'm glad that at least we are the ones who are here when they are dying, because there's nothing sadder than, there's nothing more sad than dying alone. So the beautiful death concept comes from the place of dying in your own terms, whatever it is. Right? It's not like one concept. It's what is it that you want? And this is why it is so important to establish your goals.
Yes.
What are the goals?
You're still
what are your real expectations? What is real possible based on how your condition is?
Okay.
Whether you want to accept it or not, this is what is possible. You might be in denial. You might have a second opinion that might tell you something a little bit different, but at the end of the day, the outcome is going to be the same. So what are your real terms? And what can we do so we can make sure that you get your healthcare on your own terms? And then when we're talking about death, that you actually die on your own terms. What does it mean? I want to die at home. I want to be with my dogs. I want to be with my kids. I want to be with my grandkids. I don't want to die in a hospital. I don't want to be brought back to an emergency room to get a procedure that is just going to be a band-aid. It's not going to solve anything. So having those concepts well defined is what actually lead to the concept of the beautiful death.
Yes, and I love what you're saying, what you said there too, because you really said a lot, and that is that the palliative care is going to explore all the options thoroughly.
Right.
And going to support you. You're going to also know when it's time to transition to hospice, probably.
Correct.
And then be able to provide the resources to support the family and the patient to have that process be as peaceful and, as planned as possible, so that it takes a lot of the burden of that guessing and that, oh God, because I feel like with caregivers, like for instance, with my grandma, like I was telling you, well, first of all, they said, oh, you don't have to worry about that. They said it's just, they couldn't tell if it was like old blood or new blood, but they were giving her transfusions. But it didn't, in my mind, I should have thought it can't be okay. They're giving her transfusion. Like she's obviously losing blood. But they were telling me, like, don't worry, which I think was the wrong thing to do.
Well, did she pass on that admission?
Yeah, well, not in that admission. She didn't. That's when they ended up taking her to the rehab, but she only lasted and I feel like it was an insurance thing, to be honest, but because she only was in the rehab for just a few days, and then she started to swell up, and then she went back to the hospital, and then I went to stay with her in the hospital room, and then and I had told the people that she was hungry, because my family told me not to get her anything salty because they were worried about how she was just so swollen. But then I fell asleep, and then when I woke up, my grandma wasn't waking up, and her sugar had dropped down to 12.
Wow, that's extremely low.
Yeah, I mean, she ended up going into a coma. Yeah, going into a coma, and then she was in a coma for a long time until we finally said, okay, like the hospice, But that was a horrible experience. But now I realize, like, just talking to you, this is the first time I realized, she probably should have had a palliative care doctor early in the process.
Sometimes people do not want to just take the advice of understanding that there's really nothing aggressive to be done, and to focus on symptom control. So they might want to explore, and that's fine. We allow opportunities. There's no issue with it.
Yes.
So we might say, that's okay. Let's try rehab, but let's put realistic goals. If within a week you're not at least accomplishing this, and that, then it will not happen. So maybe the care you will need after going home is not going to be home health. It's going to be hospice.
Okay, I see.
Or it will be palliative care, depending on how the condition looks like.
Yeah.
Because it is, now let me tell you this, it is impossible, even after doing this for so long. I can never tell you when things are going to happen. I can give estimates and say, this condition looks like it's not going to take more than 6 months. If we continue to have complications at this rate, definitely life expectancy is less than 6 months.
Yeah.
But even when we have people who are actively dying, a lot of people ask me, a lot of family members ask me, like, when is it going to happen? When is my relative going to pass? And I tell them, like,
you can't say that.
It's impossible. Even if I have to guess or bet on it, I can't.
Yeah. And you don't want to. You almost don't want to either.
But I tell them, you know what? It could happen today. It might take a couple more days.
Yeah.
So we give ranges of short days, long days, short weeks, long weeks, short month, long month.
Yes.
That's how we can phrase it. And it's just best to do it that way.
Yes. Okay. Oh, there's so much I could talk to you about, but I, totally respect your time and your expertise. And so I know that, you were saying that you are on television, that you talk, and you're about to do a medical or a mental health series. And this is on television.
Channel 26, Univision. And then KTSM is called El Paso Health Minute. Oh. For Channel 26, for Univision, it's called Tu Consulta. It comes every Thursday, 5:30 p.m.
Okay, Tu Consulta?
Tu Consulta, which is like your consult.
Oh, Tu Consulta. Okay. Right.
And then on KTSM is El Paso Health Minute.
El Paso
just 1 minute, just short answers to particular health questions. So.
Well, that's wonderful. Okay, so we are definitely going to make sure that we tune into Dr. Burgos for that as well. And lastly, I would love to ask you, what is it that you do best in El Paso Healthcare?
Oh, wow. So it's a very broad question. It's tough to answer. What I do best? I think that, it depends on stages in my life. At some point, I was focusing so much on hospital medicine.
Yes.
At another point, I was focusing so much more on post-acute care medicine, which is the recovery phase of it. Mm-hmm. At some point, I was focusing more on palliative care. I think now what I'm trying to do is to make sure that I continue to find those gaps in healthcare.
Yes.
And I'm trying to fill those gaps.
Okay.
That's really what I'm doing at this point in my career. Later on, we'll see what the future has for me. But right now, I'm looking at the gaps and trying to fill the gaps.
Wonderful. Well, we are so grateful to have you in our community. Anything that I can do to support you, I would absolutely love to do that because I want to do that as well. I want to support us in being healthier because I believe that as a healthier person, we have healthier families, and we also can have better leaders for our community.
Oh, definitely.
And we need that.
Spreading information, good information is key. So you're doing a beautiful work here. So I appreciate you, making me part of it.
Well, thank you so much. And everybody make sure that you tune in. We're going to have all of Dr. Burgos' social media ready for you so that you can make sure you tap in and learn, because this right here was such a valuable conversation, and I truly, truly appreciate you. You're amazing, and keep doing what you're doing, and we're going to keep getting the word out for what you're doing. Thank you.
I appreciate it. It's been my pleasure.
Thank you. All right, bless you. Peace.